Good afternoon, everyone. My name is Jennifer Webster Syriac. I serve as Deputy Director of NIDCR, and on behalf of the American Dental Association and the National Institute for Dental and Craniofacial Research, I would like to welcome you to this webinar series. It's structured to bring the latest evidence related to caries disease prevention, multi-level interventions, their impact, and their uptake according to data-driven research. As you're likely aware, oral disease, while largely preventable, is a major health burden and really affects people throughout their lifetime. And it's estimated that globally, nearly 3.5 billion people are affected by these preventable diseases that are caused by risk factors that are often modifiable, that are common to many other non-communicable diseases, among them sugar consumption and poor oral hygiene. And of course, their underlying social and commercial determinants, driven by a number of different factors at the individual level, at healthcare access, environment, economics, and others. This seminar will provide the most current research on the effectiveness of community water fluoridation. It again is part of a series where at this same time, at this same hour in 2 weeks on the 28th of February, we'll be talking about sealants and their implementation as a means of decay prevention. But today we're going to talk about fluoride, which is an environmental level intervention. And now in the 21st century, this still continues to be one of the most effective, cost-efficient, and socially equitable ways to promote oral health. So we'll hear about how effective it is in terms of decay prevention, the most current research. There'll be an evaluation of the research that associates fluoride with neurocognitive development, and there'll be identification of where the gaps are in research and what we need to look at in the future. It is my pleasure to turn the program over to Dr. Kalecki, Chair of the National Fluoridation Committee, who will moderate the panel with our experts, Drs. Jay Kumar and Dr. Scott Tomar.
Good afternoon, everyone in the Eastern and Central time zone and Mountain time zones. Good morning. I'm Dr. Christopher Dalecki, and I'm the chair of the ADA's National Fluoridation Advisory Committee. And it's my extreme honor to introduce each of our two presenters this morning. First presenter will be Dr. Scott Tomar. Dr. Tomar is a professor and associate dean for the Prevention and Public Health Sciences at the University of Illinois, Chicago College of Dentistry. He served as the Epidemic Intelligence Service Officer with the Centers for Disease Control and Prevention, and as a diplomat of the American Board of Dental Public Health. He has served as the president of the American Board of Dental Public Health and the Oral Health section of the American Public Health Association. It was with extreme honor and privilege that I would like to introduce Dr. Scott Tomar. Scott, please take it away.
All right. Thank you very much to Dr. Dalecki, and my thanks also to ADA and NIDCR for this opportunity, and thank you all for being here. I will attempt to share my slides, and hopefully this works. Can everybody see those slides okay? All right. So I'm just going to go through some of the high-level evidence that we have showing that community water fluoridation is still a safe and effective strategy for caries prevention, not just in the United States, but in many other countries. So we'll talk about some of the high-quality systematic reviews that have been published on community water fluoridation for caries prevention. Some of the data we have on what happens when the community water fluoridation stops. Some data on the cost savings, which really makes water fluoridation fairly unique. We do not have a lot of public health measures that not only prevent disease, but actually save money. And then we'll talk about a few research gaps that probably need to be addressed. So for those who aren't aware, fluoridation is the process of adjusting the naturally occurring fluoride levels in drinking water to an optimal level for the purpose of preventing dental caries. I'm not going to go through the whole history of, but for those who aren't aware of what we're talking about. So we've seen at least in the early years pretty steady growth in the percentage of the U.S. population that received fluoridated water. I have a little asterisk on there showing no, it didn't decline in 2016. There was a little difference in the methodology used to calculate that. But we now have about 63% of the U.S. population receiving the benefits of community water fluoridation, about 74% of those who are on public water systems. And we have large parts of the country, mostly for the Midwest and eastern parts of the U.S., as well as some parts of the South that have very high levels, very widespread use of water fluoridation in those states. Although we still have a few states that remain on the low side in terms of the percentage of their population receiving fluoridation. These are data that were in the 2018 ADA fluoridation facts. We're actually in the process of updating it, although the data have not changed too much. But we've already fluoridated most of the large cities in the U.S., at least as of when this was put together. 44 of the 50 largest U.S. cities are fluoridated. But we often forget that there's an awful lot of community water systems in the United States, over 51,000 separate water systems. And so while we've reached a large proportion of the population and most major cities, we still have about 33,000 or about 2/3 of community water systems in this country are not fluoridated. And most of the remaining non-fluoridated systems are primarily pretty small systems. They are both a logistic and financial challenge to try to expand fluoridation to those smaller water systems. But there actually has been technology developed in just recent years to try to make community water fluoridation more cost-effective and more feasible in some of these smaller systems. CDC supported the development of a delivery system by a company known as Casey Industries based in Florida, and they've partnered with another company to develop this system. It's actually now been approved by NSF and ANSI and UL to be used for particularly for delivering community water fluoridation in these smaller systems, and it's actually just come online within the past year and a half or so in several small communities, and there's actually quite a bit of interest in bringing this into a number of communities that have not yet been able to fluoridate. So the crux of what I was asked to talk about is community water fluoridation still effective in preventing caries? Fluoridation has now been around for quite a while, but this question keeps coming up, particularly in when some of the smaller counties and communities look at water fluoridation and say, well, yeah, maybe it worked years ago. Is it still effective? And so what I typically turn to is the highest level evidence that we have, which is high quality systematic reviews. And I have a list here of those that I can identify, primarily done by very reputable organizations or ministries of health that have been published over the past 25 years or so. And so there's at least 7 high quality systematic reviews that I found that have answered this. They've all used slightly different definitions, different inclusion criteria, and I'll just run through some of these quickly, and you'll see that the conclusions are fairly consistent. I'd say the first, at least of those that included this, that came out within the past 25 years. The first one, what we call the York Review, came out in 2000. And they asked, what is the effect of fluoridation of drinking water supplies on the incidence of caries? Their conclusion was at that time, the best available evidence suggests that fluoridation of drinking water does reduce caries prevalence, both as measured by the proportion of children who are caries free and by mean change in DMFT scores, both for primary teeth and for permanent teeth, with a median difference in the percentage of children who were caries free of about 15%, and a mean reduction of about 2.25 teeth. So that again, that's this is going back now 24 years. That was updated by the Community Preventive Task Force about 13 years after that came out. So they added some additional studies, but again, the conclusions really didn't change. And that task force, continued to recommend community water fluoridation based on, and these are their words, based on strong evidence of effectiveness in reducing dental caries across populations. And Dr. Kumar will talk about the adverse health effects, but they did also note no evidence that community water fluoridation resulted in severe dental fluorosis. The Cochrane review, considered somewhat of the gold standard of systematic reviews. They're actually in the process of doing an updated review now, but their most recent published review came out in 2015. They use a much more stringent inclusion criteria for the studies that they included. So they only included prospective studies with a concurrent control. So in other words, they measured people within the same population over time with at least two points in time. Although consistent with the earlier reviews, also found about a 35% reduction in DMFT in the primary dentition, about 26% in permanent dentition, compared to the median and the control groups. Although they did note that most of the studies they included were done prior to 1975. Again, not to say that were not valid, but that was just an observation that they had. And again, the Cochrane group is in the process of developing an updated systematic review, even as we speak. Australia, which also is very heavily fluoridated, about 90% of the Australian population actually receives fluoridated drinking water. That they had a large review on the topic in 2017. And so the question asked was, what is the effect of water fluoridation? And on the slide, it's got their definition of that. Again, in their review, they found the community water fluoridation reduced the incidence of dental caries in both deciduous and permanent teeth by about 35%, and increased the proportion of children who had no caries by about 15%. So again, quite consistent with the earlier reviews that I had mentioned. And then the most recent one I found what was done in Brazil. Brazil actually also has fairly wide spread use of community water fluoridation. They purposely, in part because of some of the comments that you saw from the Cochrane review, they purposely limited their review to much more recent studies, those done 1995 or later, and compared the prevalence in fluoridated and non-fluoridated communities. And in their review, they found that in the primary dentition in fluoridated communities compared to non-fluoridated communities, prevalence of caries was about 42% lower in the primary dentition, lower mean, lowercase DMFT, about 57% lower prevalence in permanent dentition, with about 0.61 lower mean DMFT in fluoridated communities. So again, all these, they use slightly different inclusion criteria, slightly different ways of addressing the question of effectiveness, but all incredibly consistent. An interesting study done by a colleague of mine here at UIC a few years ago was, asking the question of whether community water fluoridation reduced the prevalence of dental surgery for young kids. This is, as was mentioned in the introduction to the seminar, this is a disease that is preventable. It takes a number of different strategies to prevent early childhood caries. But this particular study looked at whether there was a difference in the prevalence of dental surgery in communities with lower levels of fluoride in the drinking water, compared to fluoridated communities, and actually found a pretty strong linear association between the prevalence of dental surgery and the proportion of the county population that had fluoridated water. So again, not necessarily causal, but consistent with what we would expect based on all the systematic reviews that I just showed. The question that really comes up a lot these days, particularly when we're involved with defending fluoridation programs that are already in place, is what happens when fluoridation stops? And we actually do have some evidence from a number of different communities and a country that have ceased water fluoridation as to what happens to caries in those communities. So in a series of studies that have been done in Alberta province in Canada, both Calgary and Edmonton, the two largest cities in Alberta, were both fluoridated. Calgary stopped community water fluoridation in 2011. And so they've actually done a series of studies over time looking at prevalence of caries in those two communities over time. And as shown in the red lines on these two charts, caries in Calgary, which actually started somewhat slightly lower than in Edmonton, actually now significantly higher in higher prevalence of caries in the primary dentition overall, and particularly on smooth surfaces in the primary dentition. Again, consistent with what we would expect of how how fluoridation works and what we expect based on, again, all the evidence that I summarized of those in those systematic reviews. Israel, another interesting case. They had started national fluoridation scheme around 2002. Unfortunately, that program was stopped in 2015. The Ministry of Health decided to stop community water fluoridation in Israel, and so that chart you see, the bar chart you see on the left, was really at baseline in 2014, comparing the number of treatments done in one of the largest providers of children's dental services in Israel. And so they found even in 2014 a significant difference in the mean number of treatments for caries related procedures significantly lower in communities that had fluoridation or were partially fluoridated compared to non-fluoridated. And then what they've shown, over time, throughout their system, was pretty much flat. That those the taller bars on here are restorative care, and I know it's hard to see that but on the left side of this chart, this is 2014, 2015. This is extractions and restorative procedures, and we saw they were fairly flat 2014, 2015, and then since then, the mean number of restorative treatments has continued to increase every year since fluoridation stopped. So again, not necessarily causal data, but consistent with what we would expect. And we saw a similar thing with in Alaska, comparing changes in Medicaid caries-related dental charges in Juneau and Anchorage. Both had been fluoridated, and then Juneau stopped fluoridation in 2003, and this shows the amount of the change in the average cost of Medicaid caries-related dental charges in those two communities since then. So these the clear bars are for Juneau, and the filled bars showing changes in Anchorage, pretty much across all age groups. Much higher increases in these caries-related dental charges in Juneau compared to Anchorage over time. So again, there's similar to what we saw in Israel. There's a direct cost associated with stopping water fluoridation in these communities. There's actually been some formal analyses of economic cost savings associated with community water fluoridation. The Community Preventive Services Task Force did a systematic review of this back in 2013. At that time, they estimated the per capita annual benefit of, between, about $5 and $93, again, differed pretty dramatically depending on the size of the community, geographic differences in labor costs, and so on. We did a more recent study, came out in 2016, and based on those data, we estimated that water fluoridation has a net savings of about $6.8 billion in averted treatment costs, which translates actually into an incredible return on investment of about 20 to 1. Again, there aren't many things that come close to that in public health. So one thing, again, there's probably a large, dental and health community on this webinar. One of my takeaways is, your voice is important. Often, as I mentioned, a lot of these things come up in fairly small communities. Your voice in those settings is incredibly important. So both what you say to your patients, to potentially policy makers who are among your patients, and your voice in standing up in City Hall or in county mission meetings is important. We really should be using the highest level evidence to try to guide our health policy. I've tried to give a quick overview of it, but really the evidence is actually incredibly consistent on the benefits of community water fluoridation. You can supplement that with your own expertise and experience, and really be a part of a coordinated team to try to protect and expand community water fluoridation. I know we were asked to suggest a few areas for research. I'd say, particularly in light of some of the things that came up from the Cochrane review, I think we do need some contemporary prospective cohort studies on prevention effectiveness when it's possible to do that. I think we have to continue to do economic evaluations, especially in some of the smaller communities, including those that are coming online now. And again, we still have a challenge of getting the information out there. So I think we really need some better implementation science to promote not only community water fluoridation, but consumption of tap water. We really have a lot of conspiracy theories and general mistrust to overcome, but I think there are ways we can do that. And with that, just a brief summary that the evidence is pretty consistent that it's effective, cost saving. That when we stop fluoridation, it seems to be associated with increase in caries and associated costs. And I think dentists need to communicate the best available evidence wherever they can. And with that, I thank you for your attention.
Well, thank you, Dr. Tomar, for your presentation, and particularly thank you for your suggestions on the areas of future research. I think that's very important to consider as we move into an area of water fluoridation and some of the issues that are coming forth in community water fluoridation as far as removing it from local communities and whatnot. So thank you again. So it's again an extreme honor and to introduce our next speaker, Dr. Jay Kumar. Dr. Kumar is the State Dental Director at the California Department of Health. Before his appointment, he held several positions at the New York State Department of Health from 1980 to 2015. In addition to his research assessing the impact of community water fluoridation, Dr. Kumar was influential in formulating guidelines for dental care for pregnant people and infection control in the dental offices. Extreme honor, I'd like to introduce Dr. Jay Kumar. Dr. Kumar, welcome. You may take it away.
Thank you, Dr. Delecky. Good afternoon, everyone. Thank you to ADA and to NIDCR for inviting me. I'm going to share my screen. I hope you can see my slide, and my topic is about association between low fluoride exposure and children's intelligence, a meta-analysis relevant to community water fluoridation, a paper we published last year. And I want to acknowledge the contribution of my colleagues, Dr. Mark Moss, Hongyu Liu, and Susan Fisher-Owens. So in the past, most reports about adverse effects of fluoride have focused in drinking water have focused on teeth and bones because of fluoride's affinity towards calcified tissues. Recently, many studies and reviews have examined the associations between drinking water fluoride and neurodevelopmental deficits or dysfunction, and have generated concerns about human exposure to fluoride in drinking water. I was a reviewer of the National Academy's review of the National Toxicology Program reports regarding this issue. When I read those reports, I was astounded when I read that reports that characterize the secondary data analysis projects using convenient sampling as high-quality studies. The standards for discovering a new effect should be very high, in my opinion, and should use causal inference models as opposed to program evaluation of a well-established program like community water fluoridation. So I assembled a team with expertise in several disciplines and decided to conduct a meta-analysis. So my presentation is about mostly low fluoride exposure. Also, I have some data about high fluoride exposure because I want to contrast the effects between those two levels of exposure. I want to give some background. In 2006, the National Research Council report published regarding fluoride in drinking water. It was a report requested by the EPA, and I was a member of that committee that looked at all effects, including IQ deficits related to fluoride exposure. That report recommended more research to clarify fluoride's effect on brain chemistry and function, and also IQ. So NRC report recommended that the EPA should update the risk assessment. So in 2010, the US EPA Office of Water reassessed the human dose response data on dental fluorosis, skeletal fluorosis, and also on skeletal fractures. So EPA selected severe dental fluorosis as a clinical endpoint and published a report with a benchmark dose of 2.1 and a lower limit of 1.8 milligrams per liter. In 2015, the US Public Health Service issued updated recommendations for fluoride concentration in drinking water to prevent dental caries. So in 2016, the National Toxicology Program published a systematic review of animal studies and identified lack of data relevant to community water fluoridation. Then NTP conducted an animal study and found no evidence of neurotoxicity in that animal study. So in 2019, NTP issued a draft report on neurodevelopmental and cognitive health effects, and that report is currently under review. So the National Toxicology Program report published in 2022 had this statement. It was also there in the previous versions of the reports, somewhat very similar. The latest report does not include a determination of neurodevelopmental hazard at any level. However, the statement, the report's conclusion is summarized here. The summary states that the authors have moderate confidence that higher fluoride, defined as exceeding WHO value of 1.5 milligrams per liter of fluoride, is consistently associated with lower IQ in children. However, the authors recommended more studies to fully understand the potential for lower fluoride exposure to affect children's IQ. It appears their moderate confidence is based on the consistency of the association from observational studies, mainly cross-sectional studies from endemic fluorosis areas. So I want to talk briefly about a paper published by one of the leaders in meta-analysis, Matthias Egger and colleagues. And the title of the article is Spurious Precision, Meta-Analysis of Observational Studies. They have a series of articles in BMJ. And meta-analysis was designed for clinical trials and later adapted for observational studies. So one has to be really cautious, according to them, because when you combine multiple studies, you have large number and it gives you very precise estimate of the effect, but that effect may be spurious. So as you can see in this graph, smoking increased the relative risk for suicide consistently in all 4 high-quality cohort studies. There is a dose-response relationship. However, such a relationship between smoking and suicide is implausible. So there must be a confounder in this case. However, so this relationship is implausible. There is no mechanism for smoking to cause suicide. Similarly, the authors show that observational studies of beta carotene and cardiovascular mortality, and most of the observational studies show preventive benefits, and there is a plausible explanation because fruits and vegetables, antioxidants, they're all good. So there is some plausibility. However, the clinical trials in this case showed the opposite effect. So the authors warn that the example illustrates that in meta-analysis of observational studies, the analyst may well be simply producing tight confidence interval around spurious results. So last year, we published this paper examining the association between low fluoride exposure and children's intelligence. We posed a question: does fluoride recommended for caries prevention decrease children's cognition and IQ scores? And what are some of the limitations of these studies? And what are the recommendations for future research? Our finding was null, so that means no effect. And as you all know, null studies are challenging to publish. So generally there is publication bias, and that may be a significant issue affecting fluoride IQ literature. For example, there's an article published by Zhu in, I think in 2020, Zhu and colleagues from China. It was from an endemic fluorosis area, and all children had normal intelligence with an average score of about 120. And still, they reported negative effect, although the effect at low levels was null. So that paper was later retracted because the editor got the data, analyzed, found the report, their interpretation was not consistent with the analysis of the data. And so the editor retracted that paper. So we found that except for 2 population-based cohort studies from New Zealand and Spain, all studies are probably at high risk of bias. Other authors, as you can see here, Miranda, Veneri, and Gopu have also expressed that concern with this, these types of studies. Whereas Duan, I think, is the only one who didn't find that. So we started with Duan's meta-analysis and added more studies. We found 28 publications for the standardized mean difference analysis, some from fluoridated from endemic areas and 8 from non-endemic fluorosis area. We also looked at urinary fluoride regression analysis and from non-endemic fluoride areas. And we found about 5 publications, some with urinary fluoride exposure and some with maternal urinary fluoride exposure. We updated the meta-analysis for this presentation. We found 2 studies from endemic areas, Ahmed from Pakistan and Feng from China, and 3 studies from non-endemic fluorosis areas, one from Lin in Taiwan, Dewey from Canada, and Granjin from Denmark, but I couldn't get the needed data from the authors to include it in the analysis. And similarly, we had some data from for Lin and Granjin's studies for regression analysis. So there are some differences between these 2 sets of analyses. So the standardized mean difference analysis is based on ecological or population level exposure, whereas the regression analysis is based on individual level exposure. So the regression coefficient is adjusted for some variables, whereas the SMD analysis is not. So also there is scientific consensus expressed in the WHO report. Although one may prefer regression coefficient analysis, the exposure used here is spot urinary fluoride, and it is not a valid biomarker of long-term exposure at the individual level. So that is a concern when we are looking at these studies. So these studies have used different indices to measure IQ or cognition, and therefore there's a need to standardize the scores. It's important to recognize the limitations of the standardized mean difference analysis. For example, the way it is derived is difference in mean IQs or cognition scores between low and high exposure groups. And it's divided by the pooled standard deviation of the group. And these are derived from cross-sectional studies. So unlike in randomized clinical trials, the 2 groups may not be comparable concerning known and unknown variables. So this is an issue with observational studies when they're using unadjusted scores. There are some concerns with respect to regression coefficient analysis, as I said. One is the use of spot urinary fluoride. The other one is the variables used. It's not clear in these analyses whether the authors are using the causal inference model or whether they are using a prediction model in their analysis. So looking at the standardized mean difference meta-analysis results, we updated it, and there is not a whole lot of difference between the updated result and the previous, so it didn't change. Addition of other studies didn't change the results. So as you can see from the top, when we compared higher fluoride exposure, that is about 3.7 milligram with lower fluoride exposure about 0.6, there is an effect. So the effect is negative 0.39, but there is high heterogeneity. It is observed here. And when we compared the low fluoride exposure, the effect is in the other direction, positive, not statistically significant, but low heterogeneity when we look at it. So the pooled effect size in areas relevant to community water fluoridation is not statistically significant. So this is in contrast to what was observed at higher fluoride areas or endemic fluoride areas. So we should be concerned about high heterogeneity. Although the direction is negative, the effect size varies. It reflects inconsistency in the effect sizes. So So I'm going to switch to the next slide and show the forest plot. And there is a pattern here. So these are all the studies listed by year. And when you look at the forest plot, it's clear that studies conducted prior to 2015 show an effect, whereas those studies conducted after 2015 do not show an effect. And actually, after 2015, there are some studies like you from endemic areas, Ahmad from Pakistan, and also Feng from China, all from endemic fluorosis areas. But either the effect is negligible, small, negligible, or actually in the opposite direction. So Ionides found that the effect sizes for many association, when first discovered and published in the scientific literature, are often inflated and do not reflect the smaller effect sizes reported later. He attributes this to the fact that the hallmark of discovery is the performance of exploratory analysis. So this may also reflect the fact that as study designs address the limitations, the effects become smaller or entirely disappear. So here I summarize the differences between studies conducted. So the endemic and non-endemic areas, and also all studies. So the key takeaway from our analysis is that these two sets of data should not be combined because of the heterogeneity in the effect sizes. As you can see, so that's our main takeaway from this analysis. And there are many differences between studies conducted in endemic and non-endemic areas. Of course, the first one is the fluoride concentration difference between high and fluoride exposure groups. As you can see, in endemic areas, it is 3, whereas it was 0.6. And in one case, you see high heterogeneity, and the other one low. And the Medline Index Journal, as you can see, most of the studies coming from endemic areas are not published in Medline Index journals. And the studied year is also different. And many of these studies do not have socioeconomic data and other confounders. And one important difference is fluoride exposure data. In endemic areas, it's usually based on surveys, geological surveys, and those are conducted infrequently, especially when the source of water is well water is in rural areas. They may take a sample of wells occasionally to measure fluoride exposure, as opposed to in fluoridated areas where the fluoride level is monitored on a daily basis and averaged across months and years. So we have very good data from fluoridated areas and in countries like the US where fluoride is monitored on a regular basis. The other issue is outcome data. We could not find reliability assessment data in most of the studies on IQ. And the bias in standard error is a major issue, especially when it comes to meta-analysis, because it is pooled and combined. It plays a huge role, and that's the reason why the National Academy's report has a whole section discussing about the bias in standard error. So this heterogeneity has to be explained. And in the case of fluoride and IQ, Duan conducted a series of analysis, but could not explain the effect based on dose or any of the other variables, and he attributed it to the lack of socioeconomic data in the analysis. So here, Matthias Egger and colleagues warn us about heterogeneity in published observational meta-analysis and impact. For example, saturated fat intake and breast cancer. There was high heterogeneity when the results of case control studies and cohort studies are combined. And when they are separated, as you can see, With case control studies, the relative effect was statistically significant, whereas with respect to cohort studies, it was below 1. So it is similar with he cites 4 different examples: intermittent sunlight and melanoma, dietary calcium intake and systemic blood pressure, and formaldehyde and cancer. So that our findings with respect to urinary fluoride was very similar, except one study. This is the salt fluoridation, and this is the Mexico study, element cohort from the Mexico, where salt fluoridation was the exposure. And that's the study where they found negative effect. And salt, the source of fluoride is salt, and salt is linked to unhealthy diet. So it's potentially a confounder, and that needs to be addressed if you want to thoroughly assess the effect with respect to fluoride when it is derived from salt. So that brings me to this study recently published from Denmark. It's the Odense child cohort study, a large study, again, a secondary data analysis project. And the authors, this publication is unique in that there are 2 studies combined in one publication. So the first one was the analysis of the Odense child cohort study, and the second was a joint analysis combining 3 studies. So as the title says, performance at school age in 3 prospective studies, although not all prospective studies studied school-age children completely. So the authors, the results of the analysis is in the Odense child cohort study, urine fluoride concentration varied between 0.08 and 3.04 with a median of 0.52. I think the average was 0.58, but were not significantly associated with full-scale IQ at 7 years. So interestingly, Denmark has very low levels of fluoride in drinking water. So the authors think the fluoride is coming from mostly tea, although alcohol is known to contain, certain types of alcohol is known to contain fluoride. So the second part of their analysis dealt with this joint analysis combining 3 different cohort studies. As you can see, the authors reported that there is no statistically significant difference shown in the circle in IQ response to the dose of fluoride among the 3 cohorts. It means that all 3 samples came from the same population. However, the authors used a coefficient of -94, and that's not what they reported in the text. So we decided to include the regression coefficient reported from the text. And when I included 3 studies and analyzed, the effect size was not statistically significant. When all 4 cohort studies, that's the cohort study from Spain, was also included, as you can see, it was not statistically significant, and the heterogeneity was very high. So EPA has guidelines for when to combine different data sets. As you can see here on the slide, their criteria says it's plausible that multiple data combine multiple data sets, but it should represent a homogeneous picture of the dose response. In other words, the responses at doses common to 2 or more data sets are essentially the same and statistically undifferentiable. So I looked at the 4 cohort studies, and I don't think it meets that criterion, because if you look at the Odense child cohort study, and I estimated at lower level, it's essentially the same because the regression line is flat. So there is a 9-point difference in IQ, even at the lowest level reported in those studies. And you can also see the characteristics of the samples are different. Alcohol use in Denmark is about 25%, whereas if you look at the smoking rate in the element study, it's about 48%. Overall, Canadian study, MIREX study, has the most favorable characteristics for high IQ, whereas the element study has the least favorable characteristics. So I decided to look at how does it compare with the benchmark dose analysis conducted by EPA with respect to severe fluorosis. This is the relationship between fluoride concentration and response, using summary data, severe dental fluorosis versus mean IQ. As you can see, with respect to severe dental fluorosis, below 2 parts per million, approximately 2 parts, there is no effect at all. So this is based on one single study conducted by Dean in 1943, where confounders was not an issue. And so this is the data set EPA used for deriving the benchmark dose. Whereas with IQ or cognition score, I plotted 4 pairs from the 4 cohort studies. And as you can see, there is the visual inspection based on, so I tried to fit different models. So there is no mathematical model that can explain the dose response relationship when it comes to mean IQ and the IQ and cognition score, mean maternal urinary fluoride. So where should we do more studies? And this is the forest plot showing all the studies from low fluoride areas, and there is no statistically significant difference. And as you can see, the more recent studies from Denmark, from China, even from endemic fluorosis area, Australia, and Sweden, all of them show no effect at low levels of fluoride. So we recommended that the effect observed in endemic areas should be investigated using interventional studies. And actually, there is one right now from Canada in Calgary where they stopped the fluoridation. They compared pre and post. There was no change in IQ score. So we also recommend more scientifically robust effort, and preferably the analysis should be conducted by an independent group, and the data should be made available publicly. Thank you for listening to me.
Well, thank you, Dr. Kumar, for your insights on the null effects of fluoride on IQ, and also for your recommendations on future research. I think that's very important to consider as we move forward. So with that, now I'd like to turn it over to Dr. Jane Grover, who is the Senior Director of the ADA's Council on Advocacy for Access and Prevention. Dr. Grover, you have a few comments.
Yes, I would like to thank everyone for attending the webinar today. And we do have a few questions. Some have been answered in the chat, but I know that some of you would like to hear from the speakers regarding some of the topics that have been posed. For those questions that we cannot answer right now, we are delighted to send those out along with or provide a site where the attendees of this webinar can view those questions and answers, and also the slides from the speakers as they become available. So my first question, and I would pose it to both Dr. Tomar and Dr. Kumar, so many people are drinking bottled water. Is there a bottled water that has fluoride in it that would benefit those individuals consuming that water? Thank you.
Sure. You want to take that first, Jay? Or?
I was reading the questions. Can you repeat the question?
Of course. So many people are drinking bottled water nowadays. Is there a bottled water that has fluoride contained within it that would provide benefits? Thank you.
There are some. I don't know the brand. One has to look at the content in the label in order to get it.
So,
Scott?
And actually, I think Dr. Lentz may have posted the link on there, but yeah, there are some, but you do have to search them out. For me, one of the bigger challenges is actually promoting consumption of tap water. In many, I understand that there's been some challenges in some communities, but for most of the country, it's really high quality and really our best bet for health in a variety of domains, including oral health.
Yeah,
Great.
in California, we collaborate with our nutrition obesity prevention branch to promote the Rethink Your Drink campaign. That's a best way to promote the use of tap water.
Very good. Thank you very much. We had a very interesting question posed. In my home country, we don't have community water fluoridation, and the prevalence of early childhood caries in 4-year-olds is as high as 60%. Once we get community water fluoridation approved, what length of time would be necessary to evaluate its benefit? Thank you.
Great question. So there's, I would say of the prospective cohort studies that have been done, and I could double check this, but I believe that the shortest follow-up was maybe 3 years. I think probably 1 year you might see some change, but it's probably not sufficient period of follow-up. But yeah, I would say expect at least a several year follow-up in those communities.
Dr. Kumar, any comment on that?
Now with fluoride available from other sources, it complicates the measurement. But if you look at the old studies, like the Newberg-Kingston studies, they started seeing the effect after 2 years. It was mostly attributed to the topical effect derived from fluoride in drinking water.
Absolutely. Thank you very much. I also know that we had a question regarding caries levels so much higher in patients who do not have the benefit of community water fluoridation. What additional fluoride interventions should be offered to such patients? And is it a blanket recommendation or is it age specific? And what risk factors would you look for? Thank you.
So, there are still schedules for fluoride supplement tablets, and the American Dental Association and the American Academy of Pediatric Dentistry still have those schedules. But I'd say actually in most cases, it'll be partly risk-based recommendations. We do have the availability of topical application of fluoride varnish for folks that are at higher risk. There are fluoride rinses, but again, I think that most of the current thinking is that for people that are using fluoride toothpaste, the use of other fluorides probably somewhat risk dependent. But Dr. Kumar may have a different thought.
Yeah, as a public health program initiative, many states have promoted toothbrushing, and especially toothbrushing in Head Start, starting in Head Start and early Head Start, and to instill healthy habits. And that's a very good approach, but it becomes difficult to implement in school-age children.
Very good. All right. Well, we are nearing the end of our presentation. Again, there will be slides available. There will be answers and comments to many of your questions at a site that will be determined where the attendees can log into. So thank you very much. I'm going to turn it back over to Dr. Dalecki. Thank you.
Well, thank you, Dr. Grover. And I want to again thank our presenters, Dr. Tomar and Kumar, for their excellent presentations, as well as the participants for being here, because I know those who took the time to be part of this important webinar really value the need for fluoride in our community. So with that, I want to thank everyone one final time, and one final comment is drink up to water fluoridation. Have a great afternoon and great evening. Have a great day. Bye now.
Bye. Thank you.